everyone, and it's a great pleasure to invite you for the today's session. It's a clinical pathways in common cancer care, and I would like to invite for the program convener, Dr. Divesh Goel sir. He's a senior consultant, medical oncology, Fortis Hospital, Jaipur, to give his opening remarks. So it's over to you, sir.
So thank you, Geetika, and thank you, Horizon team. So uh, today we will start. So the basic the CME topic is the clinical pathways in common cancer. So as we all know that the cancer burden is in our India in countries very rapidly rising, and based on this, various trials have also designed as well as the research is ongoing. So I think in our in day-to-day practice, we should know that what is the changing in our day-to-day practice, what is the chemotherapy regimes, what is the diagnostic algorithms, or what is our clinical experience with this Indian patients. So actually the data is based on mostly on Western data, but nowadays the various research institutes in our India, Tata, AIMS, as well as various other cancer institutes also research is ongoing, and India is reproducing its own data. So based on this theme, so we today in the first day's talk, and we will discuss the first day in lung as well as GI cancer. So before wasting our time, so I invite Dr. Ankur Punia, who's my the best friend as colleague. He is the professor in the Mahatma Gandhi Medical College, Jaipur. And so he will deliver the topic on this vision for MATX, protein skipping NSCLC mutations. As we all know that all therapies in the lung cancer is based on the NGS panel as well as the PDL1. So we are defining and targeting each target. So the one of the targets is the MATX protein skipping mutations. So I think the Dr. Ankur Punia delivered the talk on this topic. Over to you, Dr. Ankur.
Thank you very much for this. So, topic going to discuss, I'm going to share my slides. So, are my slides visible?
You can screen is still not. Not visible, Ankur.
Still not visible.
No.
Yes, sir, it's coming. It's coming.
Yeah.
Now is it visible? Because it's showing to me.
Sir, it's showing that they are loading in the system. I think there is network issue. Yeah, they are on the screen, sir. Dr. Ankur, your slides are visible.
Okay. So, thank you. So, the topic given to me to start this meeting is a vision for MET exon 14 skipping NSCLC patients. So, now we live in the era of targeted therapy, particularly for non-small lung cancer. So, looking at this particular mutation MET, or not that much common, but still we can see it, and it has been seen in nearly in 3.4%, 3 to 4% patients in the early setting. And eventually, patient when develops resistance in also 10 to 15% patient might develop this mutation. So not the most commonest, but still a targetable mutation. You all are aware about that. These are the multiple mutations which we can see, but targeting a molecular pathway gives the best result for these patients. So this has been in the guidelines now for a long time. NCCN guidelines say that for patient with exon 14 mutation, these are the preferred therapy as are tepotinib or capmatinib. Same has been seen in the ESMO guidelines, which says the similar two molecules, and crizotinib can be used in under circumstances when we don't have access to these two drugs. So coming to tepotinib, it inhibits the oncogenic MET receptor signaling, is an 8-week competitive reversible type 1B type of inhibitor, inhibits signaling included that causes oncogenic alteration to the MET gene. So it's a type 1 inhibitor, and that's why it has a very fewer side effects because of less off-target inhibitions by this drug. So, as I already told you, it's a MET inhibitor, it inhibits MET signaling. stops the receptor, so it subsequently downstream signaling pathway are blocked. Basically, PIK3 and MAP key pathway both are blocked by this. And this aberrant signaling of cancer, it can be driven in a ligand dependent or independent manner. So by blocking the receptor, we block both the pathways, whether it because of the ligand, like HGF is the most common ligand, or whether it's ligand independent. The drug will work in either of the indications. So the data which we have for this drug comes from the VISION study, which is one of the largest study for MET exon mutation positive patients, more than 300 patients. It was the first clinical trial prospectively showed the role of a MET inhibitor, included very elderly patients with a median age of more than 70%, more than 30% of Asian patients were there in this study. And it was used in, irrespective whether patient first line, second line, or subsequent lines of therapy. So VISION study was basically a single-arm phase 2 study of tepmetko tepotinib in patient with non-small cell lung cancer who had a MET exon 14 skipping mutation. So patient were advanced stage. Either patients had not received any lines of therapy or up to 2 lines of therapy were allowed. So there were 2 cohorts and eventually they were combined and they were analyzed, cohort A and C of this study. All total 313 patients were there. 164 were treatment naive, 164 were treatment pre-treated patients. And primary endpoint was overall response rates with multiple secondary endpoints. You can see the basic baseline disease characteristics. Median age was 70, so quite old population. More or less same male females. Asian, as I already told you, around 30% patients. Performance status good. Smoking history was quite common, which is seen with MET that almost 50% patient had a history of smoking. Majority are adenocarcinoma, though it is also seen in squamous cell carcinomas as well, and brain mets, which are quite common in molecularly driven lung cancer. So it is seen at baseline around 17 to 20%. Quite a good number of patients have brain metastasis. So as I already told you, this is the first trial which showed the enrolled patient prospectively, see how the patient responds to this drug. So what they did in this trial, they did a liquid as well as a tissue testing as well on different kind of patients. These are the basic characteristics which I already told you. So what was the ultimate result of overall patients? It initially, if we did a treatment naive patients who were enrolled by tissue biopsy, it showed a very good response rate of around 60%, median duration of response almost reaching 4 years at 46 months, median PFS of around 16 months, and median overall survival of 30 months. 90% patient, almost all the patient, because you look at this forest plot, almost all the patient had some sort of response to this drug. Very few patients, I'll say, had no response to this drug. So this drug works very well in patients who are treatment naive. We did a mutation testing was done on a tissue. Coming to the patient who were previously treated, who have received previous treatment, again the response rates were good, around 50%, median duration of response 10 months, median PFS 11 and a half, and median OS was around 20 months. Still, again, these patients did well. Again, we can see that most of the patient had some sort of a response, bar few patients. So this drug works well whether the patient was previously treated or is treatment naive. As I already told you, around 18-20% patient had brain metastasis. So this drug works in brain mets as well. So they're at baseline at around 18.2, 57 patients had brain mets. So intracranial disease control rate was very high, almost 90%. Two-thirds of patients showed some kind of a response, and median, intracranial median PFS was around 20 months, and median duration of response was not reached. So patient who responded continued to respond for a long period of time. We can see almost all patients have some sort of a response. And this is an example of one of the patient who had a baseline in a disease and at 36 weeks went into a complete CR. So these drugs works well in the brain as well. So coming to naive Asian patient per se, the subgroup which was around 30% in this trial, we can see response rates were quite high, almost 64%. Median duration of response again 20 months, median PFS 16 and a half months, and median OS of around again 2.5 years. Almost all the patient responded except two. So this drug works well, particularly in Asian patients where we are more likely to targeted, targets for this drug. So this drug works well as well. Again, for the previously treated patients, again, the more or less what was seen in the overall cohort, oral response rate is 50%, median duration response or median PFS 10 to 12 months and a median OS around 2 years. Again, almost bar few patients, almost everybody have some sort of a response. So this is the current landscape for MET exon 14 mutation. We have two drugs available with us, tepotinib and capmatinib. Vision trial, as I already told you, which had around 313 patients. Capmatinib approval is based on geometry trial, which has 160 patients. So potency-wise, it has been seen that tepotinib is slightly more potent drug. Brain penetration is also higher compared to capmatinib. We can see based on the intracranial response, which were around 2/3 in the 66.7% in tepotinib, which is around 50% in the capmatinib arm. Dosing is 2 tablet 450 mg. Then dosing depends on the drug. Comparing the overall response rates, it was more or less similar. Median duration of response and PFS in the first line setting was particularly very high. Even in second line setting, if you compare to capmatinib, it was on the higher side. Response rates were higher, and median PFS and median OS was much better in the second line as well, which was not that much good with capmatinib in the second line patient. First line patient still showed a good response, but second line patient didn't show a prolonged OS as well as a response. So this drug works well in first line as well as second line setting. This is more or less the same thing which I already told you. In a first line setting, on the better side, though both drug shows response, but in second line setting has a much more better superior outcomes. So this is more or less become a preferred drug in MET inhibitor, as a MET inhibitor for NSCLC. So to summarize, basically why tepotinib is the preferred choice. Largest study, vision study, 300 patients, included patients who had a liquid or a tissue biopsy. First line, median OS almost reaching 2.5 years. Median PFS around 16 months. Second line, again, median OS around 20 months. Median PFS of around a year. Almost 25% brain penetration. Almost everybody has intracranial response in 90%. We compare to an indirect comparison, though we cannot directly compare. Indirect comparison shows a median OS of around 30 versus 20 months. Simple dose usage and dose reduction can be done and is now one of the standard of care by NCCN ESMO guidelines. Thank you.
Thank you, Ankur. So we all know that you are treating more and more number of cases of lung cancer. So you are doing the NGS as well as PDL1 each and every patient, or how much number?
So NGS, I think now we have good enough. It can be done for all the patients. So NGS is being done for all the patients. PDL1, particularly, it depends. If patient can afford immunotherapy, then I will advise PDL1. If patient cannot afford, immunotherapy, otherwise I will not, push for it.
I think company assistance program is, I think we are doing NGS panel for all lung cancer patient, even in squamous, even in adenocarcinoma, we are doing in each and every patient. So
Yes.
have you find any MET mutations in your practice?
So I have seen a few patients with MET in first line and on progression as well. So, but my experience was not good, and only one patient was able to take. He had a response, but not for a long period of time. He responded for 5 to 6 months, then he progressed. Other patients were unfortunately not able to take any of the MET inhibitor.
So reason for this poor compliances or overall the drug toxicity with TAP-METCO?
Drug toxicity was not that much difficult. I have used the drug, not that much of a toxicity. Patient just had a response for a short period of time. I don't feel it's a very toxic drug.
Okay. So, so you think that the disease have progressed early as compared to data? The data is showing that the response rate is also 30 months median OS, PFS as well as.
Actually, what in patient which I used was second line patient.
Okay.
So that's why the responses were low.
Okay.
First line I was not able to use because of all the financial.
Any inputs from your side for this MAT skipping mutations?
So now we have to do NGS for each and every patient because targeted therapy will change the outcome for those patients. So we have to go for this.
Yeah. So thank you, Ankur, for this talk, and thank you, Mark, for giving this session. So for this next talk, I invite my younger friend, Dr. Pulkit Nag. He is consultant medical oncologist at Apex Hospital, Jaipur, and he will and the session is sponsored by the AstraZeneca. So he will deliver the talk on the treatment dilemma, monotherapy versus the combination treatment in advanced EGFR mutant NSCLC. So as we all know, that the monotherapy of osimertinib versus osi plus carbopem. So I think Pulkit will explain in better way. So where this combination is much beneficial compared to the single monotherapy. So over to you, Pulkit.
Thank you, sir, and good evening to you. I'll just share my slides.
Yeah, your slide is visible.
Yeah, I think it's full screen now.
Yeah. No. Do full screen.
Yeah, I have already done it, sir. Now it's
Yeah.
full screen.
Yeah, full
Okay.
screen.
Yeah, okay. So, yeah, as sir has already explained, monotherapy versus combination treatment in advanced EGFR mutated NSCLC. I think a common practice nowadays. Let's discuss in the under these headings of what is the burden of EGFR, the risk factors, challenges in progression with monotherapy, and head-to-head comparison of mono versus combination. So we all know that EGFR mutation, as we can see on the right-hand side of the diagram, is observed in 40 to 20% of the patients with NSCLC in Asian and non-Asian population. The incidence rate is around 33 to 39% among Indian patients and the EGFR mutations are located in tyrosine kinase domain and result in increased kinase activity of EGFR, which further leads to activation of various pathways like PIK3 and MAP, leading to continuous cell proliferation. So we can clearly see on the right-hand side of the diagram that if we divide on EGFR mutation on the basis of exon, the most common two are exon 19 and exon 21, that is exon 19 deletion and exon 21 L858R substitution point mutation, together in which exon 19 deletion is contributing around 52%. So we all know the journey of TKI starting from the first generation gefitinib, that is the IPAS trial, and showing the median PFS of 9.5 months. Then come erlotinib with the optimal trial showing PFS of 13.1 months. Then come the second generation afatinib, Lux Lung 7 trial showing 11 months. And then we have dacomatinib, the first TKI who has shown how it can cross the blood-brain barrier, the famous ARCHER trial showing PFS of around 14.7 months. And then we have osimertinib, in which till now we have a 5-year, now a 9-year survival data of PFS of 18.9 months with a absolute brilliant BBB crossing ability and great effect in brain metastasis patient as depicted by the FLORA trial. So, how does TKI plus chemotherapy? What is the basic gist behind it? So, combining cytotoxic chemotherapy with an EGFR TKI chemotherapy and EGFR TKI with act synergistically by inducing the apoptosis and activating extracellular signal regulated kinase phosphorylation, which may delay the resistance. So, if they want to say is like if we give a single agent TKI, there are high chances of resistance as compared when we give the combination of chemotherapy along with TKI. So oral TKI decreases the thymidylate synthetase level, which may enhance pemetrexed efficiency. So this is why it is called that it has a synergistic effect in adenocarcinoma lung. So these are the previous trials with early generation TKI plus chemotherapy. And as we can see on the right-hand side that the CLGB trial and various other trials with a combination of peclicarbo plus erlotinib, PEM carbo plus gefitinib, single agent PEM plus gefitinib or PEM carbo plus gefitinib, either concurrent or sequential in comparison with the single agent TKI. And I think we can see that there is a difference of overall response rate, the difference of 4 to 5 months in PFS as well as the overall survival in months. So let's see how does the third generation TKI, that is osimertinib, has worked with the combination of chemotherapy. So we all know, aware of the trial FLORA-2, that is the trial design is osimertinib versus osimertinib plus chemotherapy. It is a de novo trial we are giving in the first line settings, patient with untreated, locally advanced or metastatic EGFR mutated NSCLC. This is the inclusion criteria, age greater than 18, pathologically confirmed non-squamous NSCLC with EGFR exon 19 or L858R with the performance status of 0 to 1, no prior systemic therapy. The stable CNS metastases were allowed and brain scans were done at the baseline. So the stratification was done on the basis of race as well as on the basis of performance status as well as EGFR mutation. So the pemetrexed 500 mg meter square and carboplatin or cisplatin for 4 cycles for platinum-based treatment. After that, followed by maintenance osimertinib versus osimertinib. So with the primary endpoint was PFS and along with the BACR assessment, and secondary endpoint are OS, ORR, DOR, and other health quality health-related quality of life safety. So this is the baseline characteristics matching across both the arms, with 40% of the patient having CNS metastasis as a baseline. So this is quite a significant number of 40% with the CNS metastasis, in which we can see the combination works better or the single agent osimertinib. So coming to the KPS survival curve, we can clearly see that the orange curve, that is the osimertinib plus platinum pemetrexed, has shown a significant PFS benefit, that is 25.5 months, along with the 16 months. Along overall 9 months benefit has been seen in the combination of chemotherapy along with the osimertinib and with a significant p-value. So the median PFS was improved by around 8.8 months with the combination therapy, and it was maintained till 4 to 5 years. So as per the BICR data also, we can see that in 2 years, the difference of 62% versus 47% of PFS, and also maintained the separation of curve is maintained up to 33 months. And the difference is around 29.4 versus 20 months. So the same around 9.5 months better PFS survival benefit of combination of osimertinib plus platinum and pemetrexed based therapy along with versus single agent TKI. So this is the forest plot, and it has shown that whether if we compare the race or the sex or the EGFR mutation location or the ages or the smoking history, the type of EGFR, the performance status, and the CNS status, among all these, the PFS benefit was consistent in the combination of osimertinib plus TKI. The crux point I want to mention is the WHO performance status, that is 0 to 1. In 2 and 3, the things might go different, which I'll discuss in the further slides. So the PFS per investigation with or without CNS metastasis at baseline, that is, we can see on the left-hand side with CNS metastasis, it is 24.9 versus 13.8 months, very significant separation of curve, and without CNS metastasis, it is 27.6 versus 21 months. So the moral is that patient with CNS metastasis had a median PFS of 25 months with a hazard ratio of 0.47. It's quite significant benefit in the combination of osimertinib plus cytotoxic chemotherapy. So the type of EGFR mutation, if you see, it is the separation is almost equal in EGFR exon 19 deletion versus L858R substitution mutation. So patient with CNS Mets had a median PFS of 24.9 months with a hazard ratio of 0.47. So whether it is exon 19 deletion or L858R substitution mutation, the benefit is maintained in both the mutations. In the second interim overall survival, on the 36 months, we can see that osimertinib, the overall maturity is 41%, and the median follow for overall survival months, the range is 31.7 versus 30.5 months. It is still the maturing data for median overall survival. So if we can say that when we give the single agent TKI, that is the osimertinib, there are various acquired gene alteration leading to resistance mechanism. So when we see with single agent osimertinib in EGFR mutation, the most common is C797S mutation, although there are other mutations for RTK amplification, that is MET amplification, PIK3 mutation, that is KRAS PIK3CA mutation, cell cycle various gene amplification, and various fusions like RET, BRAF, ALK, and other. Also, RB1 loss with TP53. So no known resistance alteration have been detected. So when we compare this resistance mechanism with single agent versus combination, it is shown that the treatment with combination did not affect the resistance mechanism, and it remains similar across the FLORA and FLORA2 trial. So there is not a chance that if we add the cytotoxic chemotherapy to a single agent TKI, any of the resistance mechanism will be affected. So yeah, this is a very important slide. The only H point to use the combination of PEM carbo with osimertinib or versus single agent is that the grade 3 or events side effects were around 64% in combination, and the 48% discontinuation mostly attributed to the chemotherapy. So clearly that the grade 3 side effects and the side effects, any serious side effects were more in the combination if we combine with a single agent osimertinib. And I think the reason is because of the cytotoxic chemotherapy leading to various hematological toxicity is one of the most major prominent reason for the grade 3 side effects causing neutropenia, thrombocytopenia, and various other side effects. So obviously the combination has a large number of grade 3 side effects if we compare with the single agent osimertinib. So as I've discussed, that hematological toxicity is more So in osimertinib plus platinum pemetrexed arm, most common adverse effects were hematological toxicities known to be associated with chemotherapy, but there were no common grade 4 adverse effect in the monotherapy arm. So as you can clearly see in the diagram that most of the combination patient have anemia, diarrhea, nausea, and neutropenia, thrombocytopenia, decreased appetite are one of the most common side effects for combination. Only the dry skin rashes are almost equal in combination versus single agent osimertinib, which is a typical TKI side effects. So the hematological grade 3 adverse effects were more in the combination in more than around 15% of the patients. So I think this is the safety profile of combination trial of like NEG study, TMH study, and FLORA2 study. So in NEG it is 65 versus 31 months. In FLORA2 it is 64 versus 27. The most common side effects in all three studies were hematological. In NEG study it is the hematological was around 50 to 67. The rash was 64.7%, and liver dysfunction was 60%. In the TMS study as well as in the FLORA2, it is similar in the range of 20 to 40. And also the skin-related side effects were around 18 to 29% in FLORA2 trial. So all the combination trial reported high adverse event attributable to the chemotherapy and was almost similar across all studies, in which the hematological toxicity has been the leading one. So what are the common, if you see the head-to-head comparison between the monotherapy and the combination therapy, the FLORA and FLORA2. So in FLORA, we have combined seen the comparison of third generation osimertinib versus first generation TKI. In FLORA2, it is osimertinib plus chemo along with osimertinib. So the PFS with FLORA is 18.9 months, whereas with FLORA2, it is 25.5 months. OS benefit was 38.61, where it is not reached in FLORA2. The CNS mets with single agent TKI osimertinib, it is 15.2, whereas it is 24.9 months, which is a 10-month benefit. The most common side effect is the TKI combo, that is diarrhea and rash. And in FLORA2, we have anemia, diarrhea, as I've already discussed. And in L858R substitution mutation, the combination works very beautifully in the L858R, in which the single agent TKI have given 14 months benefit of PFS, whereas the FLORA2 has given 24.7 months. So it has shown that FLORA2 trial have increased response in L858R substitution mutation as compared to EGFR exon 19 deletion mutation. So this is the newer treatment option for EGFR mutated NSCLC. In first line, we have osimertinib, single agent, combination with PEM-carbo, and also now we have amivantamab with lazertinib. Second line, we have antibody drug conjugate, amivantamab, PEM-carbo with amivantamab, and PEM-carbo, amivantamab with lazertinib. Third line, we have amivantamab with lazertinib, with the various antibody drug conjugate, PEM-carbo, and various other single agent third line chemo. Now, this is the future, the last slide, which I want to show that we are all aware of circulating tumor DNA. It is a risk adaptive trial like EGFR Shadows trial. So we give osimertinib for 3 weeks and then we check for circulating tumor DNA. Like previously and after 3 weeks, if the circulating tumor DNA comes out to be positive, that is the time if you want to add the additional therapy. And if circulating tumor DNA is negative, then we'll continue with the single agent osimertinib. So this study, it is a future study. It will answer whether will high patient with high tumor burden benefit more, and also whether it is wiser and easier to choose the combination patients in which to add chemotherapy along with osimertinib. So in summary, osimertinib in combination with platinum pemetrexed has demonstrated statistically significant and clinically meaningful improvement in PFS in comparison to monotherapy in patient with EGFR mutated and advanced NSCLC with hazard ratio of 0.62. The investigator assessed median PFS is 25 months, and the BICR assisted median PFS of 29.4 months. Additional benefit in patient with CNS Mets and with L858R mutation, in which CNS Mets 24 months and L858R mutation also around 24.7 months. The safety profiles were as expected for each treatment and were manageable with standard medical practice. The frequency and severity of adverse effects in the combination arm were highest, as we have discussed in the previous slide, with which almost subsequent meaningful reduction over the time. Thank you so much.
Yeah, thank you, Pulkit, for this nice talk.
Yes, sir.
And I just want to know the frequency of EGFR mutation in your clinical practice.
So, sir, I have around Like, sir, only for EGFR exon 19 deletion, LF5 beta obviously is the most common. The rare mutations I have seen only one or I have two patients in which I have seen the rare mutations. I did have seen. But mostly if I have seen 10 patients out of which 7 to 8 patients I have seen EGFR exon 19 deletion or LF5 beta. But if you want to ask among these two which is the most common, still I am not able to differentiate whether I am seeing LF5 beta more or EGFR exon 19 deletion more.
So which patient do you think that this combination should be given, or which patient do not suitable for this combination?
Sir, I have used in both the combination in EGFR exon 19 deletion as well as in LH5 beta. My stopping point for using this combination is because I have one of my patient landed up in a serious trouble because his ECOG performance status was around 2. He was on wheelchair and I've used the combination LH5 beta only. But the performance status was the major thing for me to decide whether to give the combination or I have given de novo and he was not able to tolerate. Finally, I have to switch over to the single agent. So as per now, sir, I cannot comment in my clinical practice that I will give it only in EGFR LH5 and not in EGFR exon 19 deletion because the difference among these two is not very significant. So I will use in both these mutations.
Okay, fine. So as I think if patient is not suitable, if PS is not allowing, so then we are giving only single agent monotherapy.
Absolutely, sir. Absolutely.
Otherwise, patient is fit, young, fit, as well as PS is better, so we can we can give the combination of regimes. So we all know that before coming to this osimertinib, we are using gefitinib, erlotinib, as well as afatinib, and various other TKIs also we are using. I think that we are using this drug in more and more number of patients, and nowadays we are more comfortable along with this chemo combination with chemotherapy. So I think
Yes.
we are using in appropriate manners as well as in wise manners, as well as we are managing each and every side effects. So thank you,
Absolutely.
Pulkit, for this talk,
Thank
and
you, sir.
thank you, Astra, for the sponsoring this session. For next topic, I invite my friend Dr. Rohit Swami. He is senior consultant medical oncologist at Narayana Hospital, as he is also is younger enthusiastic medical oncologist in Rajasthan Oncology Group fraternity. So I think he will deliver the topic on this new ADAURA trial. So over to you, Dr. Rohit.
Good evening, boss. Thank you for such a
Thank you.
gracious introduction.
Yeah, thank you.
Please, my slides are shared, and I hope my slides are visible.
Yeah.
So I'll be discussing about NeoADAURA trial, which is phase 3 study comparing osimertinib alone or with combination with chemotherapy as compared to chemotherapy in NSCT setting in EGFR mutated non-squamous cell carcinoma. Next slide, please. So key takeaway point from this study is that neoadjuvant osimertinib should be used either alone or in combination with the chemotherapy in EGFR positive NSCLC where neoadjuvant therapy is recommended. Next slide, please. So neoadjuvant chemotherapy and chemotherapy plus immunotherapy are options for resectable NSCLC, but these regimens in the neoadjuvant setting has given us only major pathological response rate of around 0 to 8% in EGFR mutated non-small cell carcinoma lung. And more effective neoadjuvant treatment helps us to complete the surgery and derive survival benefit by giving osimertinib in the adjuvant setting EGFR positive adenocarcinoma lung. An additional advantage of adding this osimertinib with the chemotherapy may lead us to increase in reduction in the disease progression, precluding surgery, improve surgical outcome, and improve long-term treatment outcome. As we can see with the chemotherapy alone, in these patients, around 15% of patient progresses with the neoadjuvant chemotherapy. On the other hand, about 62% of patients do not have lymph node downstaging and around 36% of patients do not receive adjuvant treatment because of the toxicities or because of the disease progression. So this phase 3 NeoADAURA study explores whether neoadjuvant osimertinib and chemotherapy can further improve pathological, surgical, and long-term output in resectable EGFR mutated stage 2, stage 3B NSCLC. Next slide, please. So trial design was that all the patients of EGFR positive stage 2 to stage 3B NSCLC, mostly adenocarcinomas, few were 2 or 3 patients are of large cell variant of adenocarcinoma, with age more than 80, PS01 and exon 19 deletion on L85HR mutation, and histologically, cytologically confirmed non-squamous NSCLC were randomized into 1:1:1 patient to either osimertinib alone, osimertinib with platinum doublet, or only platinum doublet, and followed by 9 weeks of these neoadjuvant therapies. All of the patient underwent surgery, and after that, investigation choice of adjuvant treatment was planned, and even osimertinib was available for adjuvant treatment in the patient who were eligible for the same. Primary endpoint of this study was major pathological response by blind independent review, and secondary endpoints were event-free survival, pathological complete response, and nodal downstaging and safety. Next slide, please. So baseline characteristics were well balanced in all the three arms, and Asians are around 75% of the population, around 25 to 27% of population in each arm were non-Asians. All were having 0 to 1 PS, and adenocarcinoma were in 100% of patient nearly. Only in the 2% of patient in OC chemotherapy arm were large cell carcinomas. And EGFR mutations at randomization were exon 19 deletion or L858R mutations. All of the patients were stage 2, stage 3, and the patients having N2 disease, which is generally a gray zone area, whether we have to give neoadjuvant chemotherapy, go for surgery or TTRT, around 40% of patients were having N2 disease, stage 3 disease. And baseline tumor size was around 4 centimeter. And around 91% of the patient in all of these three arms underwent R0 resection, followed by R0 resections after 9 weeks of neoadjuvant therapy, either osimertinib chemo, or chemotherapy alone. And serious adverse event leading to delay in surgery or related to surgery occurred in around 10% in osi plus chemotherapy arm, 7% in chemotherapy alone arm, and 5% in osimertinib arm. So generally, side effects were chemotherapy driven, and no patient died within 30 days of surgery. So it was well tolerated combination of osimertinib and chemotherapy, and doesn't lead to delay in the surgery because of toxicities. Next slide, please. So reason for not undergoing completion surgery or R0 resection. So majority was because of disease progression. So 2% of patient in the osimertinib and chemotherapy arm had disease progression. Similarly, 2% of the patient in the osi mono arm had disease progression, because of which were not able to undergo surgery. But in the chemotherapy arm, around 80%, around 8% of patients had progressive disease and were not able to undergo definitive surgery. And not going under definitive surgery because of toxicity was seen in 1% of chemotherapy in osimertinib arm, and 6% of the patient in chemo plus osimertinib arm didn't underwent surgery because of other reasons, because of the patient-directed reasons or other reasons. Similarly, 5% of patient in chemotherapy arm didn't underwent surgery. Next slide, please. Next slide. So coming to primary endpoint of this study, major pathological response rate was statistically significant containing arm. Whether it was osimertinib chemotherapy arm or osimertinib alone arm, there was significant difference in major pathological response by the addition of osimertinib to chemotherapy. And as we can see, if we compare osimertinib and chemotherapy arm with the chemotherapy alone arm, so difference was around 24% in overall response rate. And if we compare osimertinib with chemotherapy arm, difference was around 23%. Next slide, please. And if we see major pathological response benefit as per the various subgroups which are assessed in this study, predefined subgroups. So almost all subgroups had derived benefit in the major pathological response with addition of osimertinib. Whatever the sex or PS or race or smoking history, presence or absence, EGFR mutation type, either exon 19 deletion or L858R mutation was there, and whether it was disease stage 2 or stage 3, or whether on the baseline this liquid biopsy was positive or not. Next slide, please. Similarly, there was benefit with the mono osimertinib as compared to chemotherapy alone in all of these subgroups. Next slide, please. So depth of pathological response. So there was very good and very deep response with the addition of osimertinib to chemotherapy as compared to chemotherapy alone, or osimertinib as compared to chemotherapy alone. So around 50% of the patient had nodal downstaging in osimertinib plus chemotherapy arm, as well as osimertinib alone arm as compared to chemotherapy, where only 21% of patient had nodal downstaging. Next slide, please. So coming to secondary endpoint, event-free survival analysis at 15% maturity. So there was EFS benefit with the addition in the osimertinib plus chemotherapy arm as compared to chemotherapy alone. Hazard ratio was 0.5, and osimertinib alone arm as compared to chemotherapy, hazard ratio was 0.73. Next slide. And if we see event-free survival as per major pathological response, so patient who attained major pathological response, whether in any arm, any of the three arm, there was only 2% EFS events which were noted in this study. So the patient who achieves major pathological response, either they are on chemotherapy arm or either they are on osimertinib plus chemo or osimertinib alone arm, has a better EFS. So, and more number of patient has MPR, significantly more number of patient has measured pathological response with addition of osimertinib in EGFR positive adenocarcinoma lung. Next slide, please. And if we see EFS as per the presence or absence of major pathological response, so we can see only 2% of patient has EFS event when MPR was achieved after 9 weeks of neoadjuvant therapy, as compared to 18% of patient who had event who didn't receive the major pathological response. Next slide, please. Coming to adverse events, so there was no new flag raised with the addition of osimertinib with chemotherapy. Majority of the grade 3-4 adverse events were chemotherapy directed, around 36% in OC chemotherapy arm as compared to 33% in chemotherapy alone arm. The patient receiving osimertinib alone has only 13% of grade 3-4 adverse event. And any serious adverse event were also comparable in all the arms, around 9 in chemo plus OC as compared to 5% in chemotherapy alone arm. And any grade 3-4 events were around 29% in OC in chemotherapy as compared to chemotherapy arm. Next slide, please. Coming to the most common adverse events and grade 3-4 adverse events. So generally, adverse events were guided by the chemotherapy alone, though osimertinib has few kinds of more adverse events like neutropenia, thrombocytopenia, increased rashes, increased diarrhea in this patient population. Stomatitis is also much more common with the osimertinib chemotherapy as compared to chemotherapy alone. Next slide, please. So concluding my this presentation, neoadjuvant osimertinib with or without chemotherapy demonstrated statistically significant improvement in major pathological response rate as compared to chemotherapy alone. So it was 26% in OC chemo as compared to 2% in chemotherapy, and in the osimertinib mono arm, it was 25% as compared to 2%, and resectable EGFR positive stage 2, stage 3B NSCLC. And interim EFS trends favored OC containing arms, whether OC alone or combination with chemotherapy. And only 2% of patients in this study who received major pathological response had EFS events. So receiving major pathological response after neoadjuvant therapy can give us the idea or can use as a surrogate marker for the overall survival. Over 50% of patients with baseline N2 disease has a downstaging of their nodal metastasis with OC containing arm as compared to 21% only with chemotherapy alone. And safety findings are consistent with the known profile of individualization. So neoadjuvant osimertinib with or without chemotherapy should be considered for the patient in which neoadjuvant therapy is indicated, where EGFR mutation is positive in stage 2, stage 3B and SCLC. Thank you. Thank you, everyone.
Thank you, Rohit, for this talk. Have you experienced with this regime, or have you find any suitable patient? Have you tried neoadjuvant chemotherapy regimes before surgery?
So basically, in my practice at Narayana, very rarely any patient comes who is a candidate for the surgery where you can give neoadjuvant or you can give adjuvant. Majority of the patients are metastatic disease only, or with N3 nodes where you have to go for CTIT followed by durvalumab maintenance or palliative chemotherapy. So at present, none of the patient had given any neoadjuvant therapy or any perioperative therapy.
Still, same with me, and I concur with you. Still, I have not find any stage 2A, 2B, even 3A and 3B. I think we have find all the N3, T4, N3, T4, N2. I think we almost finding, and they are not suitable for this surgical exploration, I think. So
Agreed, sir.
definitely with this trial, with this EGFR mutations, we can add on this targeted agent along with this chemotherapy. So to achieve the major pathological response. So definitely the trial is very well versed. I think that we can use in our clinical practice also. So thank you, Rohit, for this talk. And for this next talk, I invite again Dr. Ankur Punia for this IM4 study. So over to you, Dr. Ankur Punia.
Thank you again. I'll share my slides.
Geetika, share the.
So are my slides visible now?
Yeah. Please do in slide. For this slide.
Dr. Ankur, are you sharing the slides? Because I'm sharing from my side.
No, I'll share the slides.
Okay, just let me unshare it. Okay.
Are able to see my slides?
So we are able to see your slides. Can you just make it full screen?
Oh, yes. I don't know, it's PowerPoint has stopped this. Also, can you please share my, I don't know why PowerPoint has stopped responding.
So you can start.
Yeah, thank you. So thank you again. So basically, I'm going to discuss this IM4 study, a phase 3 study of lurbinectedin along with atezolizumab as a first-line maintenance treatment in patient with small cell lung cancer. Next slide. So these are the key takeaway points are that now this trial has shown overall survival and PFS benefit in the first-line maintenance setting and is more or less going to become the next standard of care in the first-line setting of extensive stage small cell lung cancer. Next slide. So as we all know that immune checkpoint inhibitors have increased, the outcomes in the patients in lung cancer, not that much in extensive stage small lung cancer, not to an impact like which we see in non-small cell lung cancer, but yes, but still the outcomes are not that much good. Very few % of patient actually responds to immunotherapy. And the thing is, in the downline, we see almost 60% of patients are not able to take the treatment in the second line setting. So we have to give the best treatment upfront to these patients. Lurbinectedin is an alkylating agent. This is approved in US and some other countries, not available to us in the second line setting post disease progression on first line chemotherapy. So in some preclinical studies, it was shown that lurbinectedin has a synergistic effect with immune checkpoint inhibitors, which was the basic of this doing this phase 3 trial. Because in earlier trials, combining immunotherapy with this drug showed improved response rate and it was pretty well tolerated. Next slide. So based on this study was planned. This IM4 study, basically patient was screened upfront for patient who didn't receive any prior treatment, didn't had any baseline metastasis. Patient were given 4 cycle of atezolizumab along with chemotherapy, and then a second screening was done basically to randomize the patients for the next. So patient were randomized into maintenance phase in between either giving atezolizumab, continuing atezolizumab post 4 cycles, or giving lurbinectedin along with atezolizumab, and the treatment was continued till progression or unacceptable toxicity. Primary endpoint was independent review, PFS, and overall survival. Next slide. This was the basic statistical plan. The patient was tested for OS, and if OS was significant, it will constitute the primary analysis, and PFS was only tested at the same time. So target hazard ratio was 0.71 with the power of 85%. Next slide. Baseline characteristics pretty well matched. A median age of around 65. Asian patients were there, not that many, around 13%. Liver mets was seen in almost 40% of the patient. PCI was given around 15% of the patient. Good performance status. LDH was normal in majority of the patients. And time from induction cycle to randomization in this maintenance phase was around 3.2 months. And response to induction therapy, CR/PR was seen in majority of the patient, and around 10% patient had a stable disease. Next slide. So this is one of the primary outcome was independent review facility PFS, which shows a good improvement. At 6 months, it was almost 41%, 18%. And even at 12 months, it was almost double, 20 versus 12%. So 1 year, almost 20% more than double the patients of control arm were on this treatment. Median PFS was more than double. It was 5.4 versus 2.1 months. Next slide. So we look at the subgroup analysis, we can see almost all kind of patients, all the patients responded to this combination irrespective of age, race, prior history, liver metastasis, all the stratification factor. This combination did well irrespective of all these risk groups. Next slide. We look at overall survival from the randomization into maintenance phase. It was again improved. It was 13.2 versus 10.6 months, almost an improvement of around 3 months. And you look at the percentage wise, it was almost 12% improvement with 56.3 versus 44.1 month, 1%. So basically more than half of the patients were alive at more than 1 year after treatment. So which is a very big thing for small cell lung cancer. Next slide. But we have to look at that this 13.2 months at the start of maintenance. Before that, we have to include that induction treatment of 3.2 months. So overall, if we see the median OS was in the tune of around 16.5 months, which is very, very good for a patient with small cell lung cancer compared to a year, which we see usually with the standard of therapy. Next slide. So looking at this subgroup analysis, again, if you look at by overall survival, again, all the patients had a response. Irrespective of race, or there were fewer patients based on that upper limit of LDH or race, but still majority of the patient responded and had a good, better overall survival irrespective of all the stratification factors. Next slide. Looking at the response rates were pretty high in the combination term, which we expect of giving a combination. So it almost 35% patient had a confirmed objective response rate compared to 20%. Sorry, 20 versus 10%. There were more CRs, more PRs, more stable disease, and very less number of progressive disease in the combination arm. Duration of response was 9 months versus 5.6 months. Next slide. So eventually we know the patient will progress. Majority of the patient, almost half of the patients still received a further line of therapy, which is not that much common, I will say, for small cell lung cancer patient to receive this many patients, which has been tuned with the real world setting as well, that less than 50% of the patient will eventually receive a second line therapy. And at the time of cutoff of this data collection, almost 10% patient in the combination arm have not still received any further treatment. Next slide. Safety, yes, we have to see safety because we are using a combination. We expect more toxicity, which has been seen. That all we look at all cause adverse events were higher, they're 97 versus 80%. Grade 3 for adverse events were higher, 38 versus 22%. Treatment related adverse events were more than 5 times, 25 versus 5%. Even grade 5 adverse events were on the higher side, they were more than double, though treatment related adverse events were not that high, but still it was high in the combination arm. Serious adverse events were almost 30%. Discontinuation was seen in almost double the patients. Drug interruption or dose modification was seen in almost 1/3 of the patient. Majority of the side effects which were increased were because of lurbinectedin, and we see more adverse events because we use this drug. Atezolizumab associated adverse events were all also on the higher side when this combination is used, and steroids were used more, almost double what we see in the control arm. So maybe there was some synergistic effect, and immunotherapy side effects were much more prominent in the combination arm. But still, the median duration of treatment was better in the combination arm, and the median number of doses which were received were higher in the combination arm. The adverse events were high, but they were pretty manageable. Next slide. So we look at the different kind of adverse event. This is basically which are more than 10%. We can see all the adverse events were higher, though majority were grade 1 or grade 2. Most common adverse events were nausea, anemia, fatigue, decreased appetite, decreased thrombocytopenia, diarrhea, vomiting. The GI and the neutropenic, this bone marrow suppression side effects were because of the use of lurbinectedin. Febrile neutropenia was seen in around 1.7% of the patients, and infections were also slightly increased, again because of this chemotherapy part which we use in this combination. Next slide. So basically, to conclude, this study demonstrated statistically significant and clinically meaningful improvement in progression-free survival as well as overall survival in the first line setting, with a hazard ratio PFS of 0.54 and OS of 0.73. And this benefit was consistent across all the subgroups, all the stratification factors. Yes, there were a higher rate of grade 3, 4 or serious adverse event, which is expected from a combination, but they were not that much of drug discontinuation, that much high of a drug discontinuation. Majority of those side effects were manageable with drug modification or dose interruptions, and it was more or less predictable. Nothing new was seen, though immuno-related adverse events were slightly higher in the combination arm. So this is basically the first phase 3 study to show an improvement of giving a maintenance treatment, adding on to the immunotherapy by adding this drug lurbinectedin, and eventually this will become the standard of care for this disease. Thank you.
Thank you, Ankur, for this talk. So just my two queries. Where you find the small cell carcinoma in Indian perspective in your clinical experience in terms of survival? And second, where you place the immunotherapies, is it more beneficial or is it just improving the PFS?
So what I feel in small cell lung cancer, actually immunotherapy benefits only around 10% of patients. And we don't know actually which 10% of patient actually benefits from immunotherapy. There is some data coming about how can we, stratify small cell lung cancer into different, there are basically 4 types of molecular subtypes. And one particular subtype has a benefit of adding immunotherapy. So that might be able to tell us in the future that which patients will actually benefit, because 90% of the patients will not benefit from immunotherapy.
So do you use the immunotherapy in each and every patient of this small cell, or you use just carbo-2?
So I will give the option to a patient. If patient can take it, then yes, definitely. We don't know which patient, but we have to give benefit of doubt to each of the patient.
So thank you, Ankur, for this talk. And definitely the one regimes we are using the immunotherapy along with this chemotherapy in a small cell cancer if the patient is affording now in our practice, in practice. So for next session, I invite Dr. Somani sir who is the Director Oncology as well as HOD in Department of Medical Oncology at HCG Cancer Center and Sumani Hospital, Jaipur. And he moderate the session on this perioperative management of this early stage lung cancer. So over to you, sir. And for the panelist is Dr. B.S. Ankit Nehra, Dr. Lalit Sharma, Dr. Preeti Agrawal, Dr. Rahul Roy, Dr. Rohit Swami, and me also, sir. Sir, I think you
Sir, Dr. B.S. Ankit sir is also not joined.
okay. Yes, sir.
He's having some
Over to
network
you, sir.
issues.
Last time I find it very difficult to share the slides at my end. Again, I am finding it difficult. Am I able to share it?
Yashika, can you please run from your side?
No, I want to make it my end. I don't know why I am not able to share it. I have my PPT on with me, so okay, this needs to be shared from here. Okay.
So tech
Okay.
support, can you please help out?
Yes, ma'am.
Okay. So little
Well, now it's
less
visible. Make it full screen.
visible. No, okay, full screen. So all my colleagues, my friends are here. Am I able to share it now? Is it on the full screen now?
Yes, sir. It's full screen. No,
Okay.
No, sir. No, sir.
Is it on full screen now?
no, sir. Now it is not in full screen mode.
Okay. Now I believe it's on
Yes,
full
yes.
screen.
Yes, sir.
Yes, sir.
So do we have with us Dr. B.S. Ankit from HCG?
No, sir. No, sir. Ankit is
No.
not.
And what about Dr. Preeti Agarwal?
Good evening, sir. I'm here.
Good evening, Dr. Preeti. Dr. Divesh has written you on the Apex Hospital. Is it correct?
No, I'm at Narayana, sir.
Sir, I
So
think
you should penalize Dr. Divesh. It's not my fault.
yes, yes, sir. It's
But I
fine.
have brought it in notice. So he should be suitably being punished or penalized for that. Dr. Rohit Swami,
Yes, sir. Good evening.
good evening, welcome. And Dr. Lalit Sharma from
Yes, sir.
Manipal Hospital, Lalit.
Good evening, sir.
Yeah, and Dr. Rahul Rai from Bikaner.
He is not here, sir. I think he's.
So the duty of all the panelists is to make the moderator more educated so I can remain updated like what they are supposed to be updated. Okay. So today a little bit discussion, the role which Dr. Divesh has given me to talk about the perioperative systemic treatment, chemotherapy or chemoiotherapy for the operable non-small cell lung cancer. So the first question goes to Dr. Preeti. How many times in the different scenario, like you are working at NH, you are working at railway also and other places, how many times you see the resectable NSCLC?
Very few patients, sir. Probably very, very few. Like,
You don't see or you don't want to see?
I don't see. I want to see.
Let's say a T3N1 comes, or let's say T3 with the mediastinal nodes less than 1 × 1 centimeter. So you don't see or you don't want to see?
So T3 with very, very less
Be
patients.
very honest. Be very honest.
I'm very honest, sir. I see very few patients who are, I think, less than 15 or less than 10% patients who are actually operable.
Ma'am, 10% is too high figure. If
Yes,
we get
yes.
10% operable,
Yeah, very, very less.
these all
Yeah.
perioperative IO chemo will be behind you.
No. I think 10% is actually very, very big number. You're correct. Very, very less.
Dr. Rahul,
Yeah.
at Bikaner, how do you try to segregate these T3N1 oblique doubtful N2 patient or T1, T2 with mediastinal nodes being reported in the PET less than 1 centimeter, and you convincingly take them as either for chemotherapy or let's say at the most chemo plus IO, chemo plus RT. Dr. Rahul from Bikaner.
Sir, Rahul is not here. Rohit is available, sir.
Okay, so Rohit, how about you?
So, sir, I'll say T3N1 on the PET-CT. I had encountered only 1 or 2 patients in my practice since last few years.
Lalit,
Almost
what about
each
you?
and every patient is stage 4.
Lalit, I don't agree with you, Rohit, but we will come to that point. Dr.
I totally
Lalit,
agree with you that most of our life becomes very difficult the moment such a scenario arises, because ascertaining the nodal stations, whether it is N0, N1 or N2, is a Herculean task in itself. By the time we have done a biopsy and we have diagnosed the patient to be lung carcinoma, the patient is already fed up, already इतनी जांचें हो गई हैं साहब, अब इसके बाद में ट्रीटमेंट क्या करना है वो बताइए. Nodal stations, doing mediastinoscopy and having further investigations is a Herculean task, but if we wish to do it in the textbook manner, that detailed counseling and that multidisciplinary approach definitely has to be there.
there was a quick comment from you. We will give you least time.
Yeah. So I think one thing, I think workup can easily done. EBUS as well as mediastinoscopy is easily available. So I think the nodal station can be addressed as early as, but I have still not seen even any early stage or these lung cancer in last 6 to 7 years. No
Okay.
single.
So 2 points I want to bring in highlight here. Not saying that in the clinical practice you people are wrong or somebody else is right. But today we talk about the neoadjuvant treatment even in the inoperable non-metastatic NSCLC. Like typically like N2. Now the trials are coming, the thought process is coming that you need to reassess them for. Second thing, even the single oligometastatic lesion with the operable primary does not exclude everyone from the benefit of the curative surgery. Like single as well brain, primary operable. You treat secondary brain, well controlled, think of doing the surgery. So what I want to bring here, that just don't make everyone as inoperable, because this bar of operability, resectability is shifting. Even the 3B patients, the trials are ongoing and now coming up, that you can think of giving them the neoadjuvant treatment and make them operable, unresectable, like locally advanced, so many other malignancy. So with that concept, that is the one thing. Second thing, this discussion is for the non-mutation positive patients. So what is the concept? Dr. Lalit, I'm coming to you. A patient who is otherwise resectable, how many times you think of doing compulsory NGS, full panel or lung specific panel to segregate them for the EGFR, thinking of the neoadjuvant treatment, or to apply IO that EGFR, ALK or ROS1 should be negative? So what is your thought process? Let's say T2 lesion is coming or T3 lesion is coming, N1 node is there, looks operable, 55, no comorbidity, no contraindication. You have the full surgical team also to operate it. So how many times you do the addiction or the mutation analysis in this patient before going for the surgery, before going for the neoadjuvant systemic treatment, including IU?
So the situation is going to be hypothetical, because day-to-day practice we are not kind of encountering such scenarios. But if the scenario be there, I would like to ascertain the molecular profile upfront itself, so that we do know what biological markers this tumor is expressing and what the both the therapeutic options and the prognostic indicators are going to be like.
So my impression is that as on today, if I'm contemplating surgery in this patient at any time, I should try to do the NGS, followed by to take the decision, because just by doublet chemotherapy, probably the purpose as on today of the neoadjuvant treatment doesn't suffice in the resectable patient. Dr. Rohit, do you agree with this statement?
Agreed, sir. Agreed. Completely agree.
Dr. Preeti, anything from your side to contribute?
I agree with the point that we should get a molecular testing before we start any neoadjuvant treatment.
Okay, so we will go quickly to the next point. And this is the overview of the clinical trials and evaluation indicators. I will be here sticking myself to the two trials, that is the Checkmate 816 and the Keynote 671. But we have a lot of other trials where we talk only about the neoadjuvant, where we talk about the adjuvant and all the available molecules with us. That is atezolizumab pembrolizumab, Pembro, Durva, Nivo, and even now the toripalimab, they are now being studied in this setting. But because only the two trials have shown the mature results of the overall survival, and probably we are also interested in the new adjuvant treatment Checkmate 816 and the Keynote 671 perioperative pembrolizumab, and as well as the Checkmate 77T, that is the extension probably of the Checkmate 816, for which we will be discussing. My understanding is that most of these trials are talking only the event-free survival as the primary, or they are talking about the major pathological response or primary or the complete pathological remission. These are the three indicators, and most of these trials, or today we talk about the 1B onwards 3A. Though now 3B can also be thought of for this purpose. So with that statement from my side, let's go that how these trials are talking about. So the key clinical data till June 2025 talks about the various parameters. The parameters are the major path CR, major molecular, major path response, complete response, surgical assessment, mortality, morbidity, R0 resection, event-free survival, and then finally the overall survival comes. So these neoadjuvant trial in the lung cancer are the different. They talk about the event-free survival. They talk about the PET-CR or major PET-CR response, and then they try to assess the patient 1B, 2A versus stage 2 and 3. They try to understand that which groups probably are the best, giving the statistically significant results, and then obviously the other parameters like the PDL1 high versus low versus negative. So do you see that these trials, this tabulation, these two tabulations are serving or sufficing the purpose for the discussion or to make the conclusion, or you would like to say, no, Dr. Somani, you are wrong somewhere? Dr. Lalit, to start with you.
So very difficult for me to comment,
So
but
be bold enough and say, Dr. Somani, you are wrong.
no, sir, I'm not trying to say that. What I'm trying to say is that probably this chart does let us know that in this particular setting, these molecules definitely might be helpful, but doing cross-trial comparisons or trying to pick one molecule over the above, this chart might not be that helpful.
Dr. Preeti.
So, what do you want to know? Whether I'm happy with this chart or not?
So these are the two tabulations I bought from someone and presented to you. Is this way of assessing the neoadjuvant systemic treatment? When I call systemic treatment, obviously it's the chemo plus IO.
Yes.
Is it sufficient, or you want to focus that you want to analyze only PET-CR, or you are happy with the event-free survival, or you will stick only to the overall survival?
So yes, we want to have overall survival, but I'm not stick to that. But yes, the ideal parameter is overall survival. But since the data has included only event-free survival as a primary analysis, and yes, event-free survival can be a surrogate marker for overall survival, but
So
overall survival remains the yardstick.
If I stick you here, overall survival are never the primary endpoint of any clinical trial in this situation.
Yes,
Why
I
you
know
want
that.
to go behind that?
So yes, the overall they have not included overall survival because the long-term follow-up is required for drug to get approved. If you take primary endpoint as overall survival, because the patients are going to survive like 5 years or more, so they have taken event-free survival as primary endpoint, and it can be one of the surrogate marker, but it cannot be the only surrogate marker. So if they would have chosen overall survival, especially
agreed with you that we remain skeptical for these sort of the parameters. Probably that doesn't give us the comfort zone. Am I right?
Yes, because especially the patients
now,
are
Divesh.
operable. Adjuvant setting, we are more concerned about overall survival rather than event-free survival.
So, Dr. Divesh, and today we have the toripalimab also available, and tomorrow more molecules will come in this direction. Will you have the temptation to extrapolate the Pembro and Nivo and will try to give only chemo plus toripalimab in this situation to cut down the cost, or you will be more comfortable with the 816 or the 671?
I think now, if we are talking, so I am now recent comfortable with this 816 and 671. So I think data will come of this toripalimab. I think in future the data will come. So just I will use. So, but my focus, where the approach of these regimes to use in the resectable state. The first part is the priority is the R0 resection and then the pathological response. So I think the first part this, and the second part is following this the event-free survival and followed by the overall survival. So how we are achieving this, the R0 resection, PCR followed by the EFS and followed by the OS in my view.
So my rule of thumb is it should be the 4 centimeter plus lesion or it should be the N positive. Suppose आपको एक लड्डू मिल गया पेरिफेरी में रखा हुआ something like 1B. Will you have the temptation to go for the surgery or thinking of the adjuvant atezolizumab or thinking of the adjuvant Adura, something like that, based on the NGS, or still you will have the temptation to go for the neoadjuvant treatment? Dr. Lalit.
I'll go for the surgery, sir, upfront, which will probably give us better molecular profile also with the whole tissue being available with us, and then go for adjuvant treatment as per the molecular profiles.
Okay, so let's move from here. So only these two trials of the overall survival data declared another positive, that is the CheckMate 816 and the 671. So probably that is the reason that all the discussions everywhere keep revolving around these two molecules or these two studies. So 816 CheckMate 81 is the Nivo based 3 weekly chemo plus Nivo 360 milligram, and then subsequently surgery. And within 6 months of treatment, and if the PET CR is there, they are very happy, but no more treatment. Plus minus chemo RT remains there depending on the outcome of the surgery. So this is about the CheckMate 816 presentation. The various statistical analysis which they have done, that is the PET CR, event-free survival, and if both are positive, then this way, that way. There are so many complications which are away from the conventional two parameters which we often see, that is the PFS, DFS, and the overall survival, which Dr. Priti was just trying to say that she will be acceptable only when it is the overall survival or some major thing is there. So with these statistical analysis plans in the various trials in this setting, are you happy, or you would like to go with Dr. Priti that no, PFS or overall survival should be there to accept the outcome of these two trials? Anybody can make the comment. Let's go back to Dr. Priti.
Yes, sir. Since we are sticking with the trial and we are taking event-free survival as one of the surrogate endpoint for overall survival. Yes, we are still skeptical, but as the data evolves, we will find out how this neoadjuvant chemoimmunotherapy goes to overall survival, especially in PD-L1 negative subsets.
So we have our own reservation and prejudice to analyze any trial, because probably that's based on our experience with the molecule, kind of the patient which we see frequently or non-frequently, the cost factors, side effects, handling the patient, drugs, so many things. So nothing is wrong or right. Probably we have to be choosy for our patients. And trial design, if you look, yes, they keep talking about the event-free survival as a common point. If you talk about the overall survival, if you talk about the pathological CR, because everyone believes that in neoadjuvant setting like head neck, like lung cancer, NSCLC, major PET CR or MPR are probably the justifiable points to assess any particular clinical trial. Now, event-free survival, if you talk about 5-year survival, Neo plus chemo versus chemo, yes, there is a definite difference. And overall survival, yes, again, there is a difference in this particular trial. That's why this trial is considered the positive to the tune of the 65%. And this survival gain starts at the end of the 1 year or maybe at the 18 months. So quite early you see improvement. And if we look about the other point, that is the PD-L1 positivity versus negativity. In the negative group, we see hardly there is a difference. And in the positive group, we see that the difference starts early. So presently, would you exclude the PD-L1, which is done on a single biopsy most of the time in resectable patient? Suppose it's a negative. Will you take it as the negative and will not give the benefit of the IO in this group of the patient? Dr. Lalit.
So PDL negative, I would be less inclined to use, and especially in resource restricted setting. And as far as PDL more than 50% is concerned, I would be rather more comfortable with IO alone, especially if the performance status is borderline.
Dr. Rohit, Dr. Lalit wants to exclude the chemo from PDL1 positive patient in neoadjuvant setting. Will you be comfortable without giving doublet and giving only IO?
In the cases if PDL1 is more than 50%, we can avoid chemotherapy and toxicity related to chemotherapy.
We are talking
because
about the neoadjuvant setting. Are the other panelists agreeing with this statement?
So I
Presently-
said rider of performance status.
Basically, I'll say, sir, that there is no study which has compared this chemo IO versus IO only. But definitely, if the patient is fit, and then I'll go with chemo plus IO. And if the patient is not fit, performance status is poor, then IO only.
So in PDL1 more than
Or
50,
either surgery.
do you feel that you will get the measured PHCR or the NPR?
I think we can get some major pathological response because generally in the lung it is always PDL1 directed outcomes. Like we can see in the metastatic setting also, if it is a more than 50% PDL1, we are comfortable going with pembrolizumab or IO alone. Similarly,
Would you like to? Yeah, please. Sorry, I'm sorry.
Similarly, it may there are fair amount of chances that we can go in the neoadjuvant setting with IO only if PS is very bad. If PS is even I will say 2 or 3, then IO alone can be the option because the patient is also not going to be upfront surgery because of the poor PS. So in these cases, we can go with
So would
neoadjuvant.
you like to make any reference or any trial for that saying that only IO can be considered in more than 50% PDL1?
So that's what I was saying. Ki there is no study at present that neoadjuvant alone can be given. Even in this Checkmate 816, I think one arm was neo and EP, which was then removed, and neo plus chemo was. And why this was done, it was not explained in this study also.
So my
So
foolish,
at present, I think there is no data.
my
to
foolish
support.
explanation is that nivolumab, even as single agent in the PDL1 positive, more than 50% is not probably used, not approved. It is only the other drugs like pembro or maybe even atezolizumab you can think of, not nivo. So
Like
maybe
it's a-
that I
pembro
will
has
not
robust
go with
data.
I will not go it with the single agent because probably that's not there. So if we look at the Keytruda overall survival in the key subgroup, the 2 points which I learned that this is not the blanket treatment for everyone. Conspicuously, we all understand that never smoker patients, they are probably not being benefited. So I don't know what is the explanation is the tumor mutation burden because of the smoking, which is giving them the response. That does not mean at all that we advocate that the continue smoking during treatment or IO. And other is in the elderly patients, more than 65, probably they are not being benefited. So we need to segregate certain patients like elderly patients or never smokers, probably where the benefit is not there. And Eastern Asian patient versus non-Eastern, probably we are not considered Eastern. That is more like the Chinese, Taiwan, or the Vietnamese, or the Korean, or the Japanese patient. But we need to understand that the separate Indian studies are not Indian data, subset analysis is not there. So we need to understand this. Also keep in the mind that the response against the, for every ethnic group of the patient is not the same. And again, for the pembrolizumab, less than 1%, probably it is not there. So probably the PDL1 negative patient, I will remain skeptical for this sort of the approach. And overall survival for the stage 1B, 2 versus 3A, again, there is a different magnitude of the benefit is the different. And the earlier stage patients, probably the magnitude of benefit is less. So do you agree with this that for 1B patient or more than 4 centimeter patient, probably you will not go if it is not like 2B or 3A patient? Dr. Rohit?
Definitely, sir. For 1B or 2, yeah, this magnitude of outcome is, I'll say EFS benefit or overall survival benefit is less. So I'll go with the upfront surgery in these patients.
So, Dr. Lalit,
Sir.
any other different view? That higher the stage, more is the benefit?
Pardon, sir. Yeah, sir. The more the disease volume, the greater has been benefit shown. So that is why in your earlier question, wherein the volume was not that much, the lesion was peripheral and it was amenable to surgery upfront, I kind of preferred going for the surgery upfront.
So probably the confidence interval with the hazard ratio for the early stage like 1B, which hardly we get it, and probably we'll have the more temptation to go for the upfront resectability, because we remain often skeptical for their NGS, which is done most of the time on the true cut biopsy, probably may not be representative, and because that is not being clubbed with the liquid biopsy for most of our patients to have the more true picture. So probably it's better that in the clinical practice, we go for the upfront surgery and then see. And overall survival by the PET-CR, that is the reason that event-free survival and the PET-CR has taken the points, because they have tried to analyze them and trying to correlate them with the overall survival. And those patients who have the PET-CR, their survival outcome is better. So it is not that overall survival maturity is required for each and every trial. The PET-CR is one of the correlating factors and being argued in favor of the PET-CR that yes, event-free survival PET-CR, you can take it as the positive outcome of these sort of the trials. And event-free survival also being taken by the PET-CR also. So that is the reason that the higher the PET-CR, higher is the event-free survival benefit and the overall survival benefit. So what will you do if you don't have the PET-CR after neoadjuvant, Nivo plus chemotherapy? Because your particular clinical trial talks only about the neoadjuvant trial. So Dr. Divesh, if you are available, if the PET-CR is not achieved, what you will do in the adjuvant setting? Let's say the resectability is done, margins are negative, probably you are not filling the role for the radiotherapy. Will you continue the neoadjuvant adjuvant same IO molecule? Will you try to incorporate more chemotherapy or change of the chemotherapy? What you will do? If Divesh is not there, then we can go back to Dr. Preeti.
So I think if PET-CR was not achieved after this neoadjuvant treatment, so definitely some sort of treatment is required for further adjuvant strategy. So I think some treatment, I think I will continue, but I think I will give the single agent Nivo will continue in my view.
Anybody else with a different view? So do you find any role for ctDNA to assess the or try to correlate it with the pathological response? Let's say PET-CR is not there and ctDNA is cleared. These all are the hypothetical, but tomorrow we may face these situations.
Sir, I think if PET-CR was not there and ctDNA is, I think, negative.
It's cleared. It's clear. It's a negative.
Cleared, yeah. So I think we can offer the observation in that scenario.
Lalit.
Manish, can I pitch in now?
Oh, yes, a big boss Lalit is there.
Thank you so much. So always a pleasure to listen to your panel. So in the first circumstance, it looks that we give, if the ctDNA is positive, then we continue the treatment. Treatment means at least IU we continue. If ctDNA has turned negative, then we can consider that yes, the monitoring can be done with ctDNA and we may stop the treatment theoretically.
If it is nivolumab.
Yes, if it is new.
If it is planned perioperative pembrolizumab, then we will continue it.
Yes, absolutely.
And if the chemotherapy, adequate chemotherapy is not given in the neoadjuvant setting, then try to give more adjuvant chemotherapy doublet. Probably patient is suitable enough post-surgery.
Right.
I think that should be our consensus statement.
I agree to that.
Yeah. So
Yeah,
we will upgrade.
Divesh is smiling. Divesh is probably have some other thoughts.
No, sir. I agree totally with you and sir.
So Divesh is more interested that we complete the things on well in the time. And we will request the organizers to upgrade Dr. Lalit Mohan Sharma also as the panelist.
Yeah.
So exploratory analysis, overall survival by ctDNA clearance was also being studied. And obviously, it is being found that those patients who have the clearance of the ctDNA, probably their outcome remains better. But that necessarily does not mean if ctDNA is not clear and you try to jump on the patient, you will achieve more. So that is not clear. So it is more like predictive marker rather than guiding you for the treatment as on today. And this question will, I think, will keep coming in every discussion, new adjuvant, at the time of the follow of the patient, how to, act upon on the ctDNA positivity, then reappearance, what you gain by positivity and by treating, by not treating. But let's have the discussion so that we have the more outcome. Keynote 671, importance of the adjuvant. Yes, those patients who receive the adjuvant treatment, their outcome probably is better versus those who do not. And that is the major difference between the NEO and the Pembro in this particular setting. But yes, NEO has also been studied as the CheckMate 770 if that is the continuation of the NEO in the adjuvant setting also. So suppose tomorrow, if you have the overall survival gain also in the CheckMate 770, then probably in the NEO also, you will go for the adjuvant setting also. And in the other molecules, if they get the overall survival like the so-called cheaper versions of the IO, like the toripalimab and other molecules which are on the horizon with the help of the many our companies like the Intas or the Zydus or the DRL, that they are trying to bring these drugs with us for our patient, which are as on today the cost effective for us, then probably we will be trying to assess these molecules also. So before I go for the conclusion, let's have a concluding remark from every panelist. Let's start with Dr. Divesh himself first. So what is his thought process, his message to everyone regarding the perioperative or neoadjuvant IO plus chemotherapy?
I think if the patient is suitable, so I think in that scenario, if locally advanced in stage 2 or 3, I will prefer to start with this the chemo plus IO combination.
And Dr. Lalit Sharma, you?
So I believe neoadjuvant IO is going to play a role in our care in early stage lung cancer, especially in patients wherein volume is on the higher side, say T3 lesion, and especially if the PD-L1 expression is decent, and in the other settings such as non-PD-L1 expressors or with low disease volumes, I might kind of weigh in the
Dr. Rohit Swami, only two
So-
sentences are permitted. Only 2 sentences are permitted.
So perioperative chemo plus IO and pembrolizumab will be my, I'll say, drug of choice as a IO to add in a perioperative setting. As compared to nivolumab neoadjuvant setting, I'll say CheckMate 816 has several flaws, and I'll wait for neoadjuvant in a perioperative setting for 770 results to come.
Dr. Preeti, 2 or 3 sentences only, please.
Sir, I don't have any preference, perioperative versus neoadjuvant. I don't know. Both seems to be similar to me. I don't know what additional adjuvant therapy is adding in the patients who have achieved pathological complete response, and how much are they going to benefit with complete continuation of immunotherapy post surgery in patients who have achieved PET-CR. So very difficult to choose. The patient who has achieved PET-CR, yes, continuation of immunotherapy. If no, if not achieved PET-CR, then probably yes. Role of adjuvant therapy, I'm still skeptical when their tumor is not there.
And I believe, Dr. Preeti, your this statement is in relation to only NSCLC. You are not making it as a generalized statement like if
No, no,
PET-CR
no.
is achieved, no more treatment is required.
No. It is just it's just in the case of non-small cell lung cancer. But CheckMate 816, they give only neoadjuvant treatment. Even the PET-CR is not achieved, they did not give adjuvant treatment. And adjuvant immunotherapy, Keynote 671, they use neoadjuvant as well as adjuvant. They use in perioperative setting. So I don't know in patients who have achieved pathological complete response, how much is this adjuvant immunotherapy's role is it's going to be there. So
And
yeah.
the final word of wisdom from Dr. Lalit Mohan Sharma.
So I think we all are learning, in fact. So Neoadjuvant IO plus chemo, yes. Post neo means perioperative, yes. IO plus chemo, both should be used. After achieving PET-CR, there are few trials, not in lung, but aware of trials in the breast and other places that even PET-CR, post PET-CR also, the IO continuation plays role in like delayed relapses.
So the information which we gathered from this panel discussion probably is relevant to say that probably the Keytruda is still the king because of the perioperative setting that we believe that more need to be done. And we don't know if after getting PCR, should we stop IO? Final answer is not there, as being argued by the my esteemed panelists. And we don't know if PD-L1 negative patient, this helps, but we still give it them. We do not segregate them the patient. Benefit is less. We don't know what to do if we don't get PCR. We continue same IO that did not work and probably will work or will not work. We don't know. We don't have the better option as of now in this particular situation. And unlike in the breast cancer, as being discussed, ADC as on today doesn't work in this scenario. That is the change of the treatment, as you just pointed it out. But still a lot of scope is there. And today we talk about the PCR in the range of the 20%, if I'm right. But the important message is probably even this perioperative, neoadjuvant, surgical, resectable, operable is best being discussed, best being assessed, best being managed with the multidisciplinary team. And I would like to share with you that multidisciplinary is the answer, and that multidisciplinary doesn't finish. Rather, I will say does not even start with the clinicians only. That is the medical, surgical, and the radiation oncologist colleague. Probably it starts from your radio imaging, your nuclear medicine colleague. It starts from the proper report of the assessment of the NSCLC, and obviously your NGS team. That what as the part of the multidisciplinary team, your critical care specialist, your anesthetist gives you the correct picture regarding the resectability and the operability and the assessment of this patient post-operatively. And obviously, when patient post-operatively will be fit enough to go for the adjuvant IO or plus minus chemotherapy. And if unfortunately margin is positive, then the incorporation of the post-operative radiotherapy also. With these words, I would like to thank all of my esteemed panelists and going back to the organizers for the further discussion. Thank you.
Yeah,
Thank
thank
you,
you,
sir.
Somani sir, and thank you all panelists. So thanks, Somani sir, for guiding us. And I think we learned more and more. I think we just see the fewer number of patients in our OPD for this session. I think I still I have acquired the knowledge in today's session. So I think very well managed and very well moderated. I think knowledgeable. So I think we will approach in perioperative lung cancer if we use chemo plus neoadjuvant. So fact, so we can use the pembro as nevo according to the data, and definitely we will use in this our routine day-to-day practice. So
only message which I would like to give again is the provocative statement which I encountered, I thrown upon Dr. Preeti was, we don't see or we don't want to see.
Yeah. So I
So
think
today when we have the more treatment options, the bar has been raised to the 20% PCR. I think we need to see more patients.
so definitely, and one thing is multidisciplinary team. So I think the even radiologist, even
Somani sir, one question.
Yeah.
Out of the box, this question. Recently, I saw that one data, Rational 315, that is showing in perioperative setting 40% PET-CR.
So I brought that slide here. Tomorrow it may show the overall survival. Probably we will shift to it. So the bar has been raised. We have more scope for this, and lot of other molecules are also going, and maybe that the bar will raise to the 40-50%. And this 315 or 351, I don't remember. Probably maybe the future answer for that.
Yeah.
But I tell you, Tarachand, one thing. Maybe that with the perioperative pembro, you achieve only 20%. But let's say tomorrow you have the biosimilar Pembro. For practical purpose, again, you will go to the chemo plus Pembro only. So for the
Yes, sir.
practical purpose, a lot of things are there.
Yeah, I was just studying 3-4 days back that the resectable lung, no? Then I found that nivolumab, data of nivolumab is only in PATH-CR patients and PD-L1 positive patients, especially in stage 3.
Yeah.
And while the pembrolizumab without PATH-CR is doing magic with lesser PATH-CR alone.
But you have to start with the one molecule in the beginning. And there is probably PDL1 may guide you that high PDL1 means you are going to achieve it or not. But the achieving PATH-CR versus achieving the benefit in the patient are the two different scenarios.
Yes, sir. That's why I saw the thing in those trials. That means I don't remember the trial name. I forgot usually.
And probably that is
numbers
the
usually.
reason that we are seeing the less patient, but still Dr. Divesh has kept this topic.
Yeah.
He
So-
understand it, but discussing the chemo plus IO in the first line, NSCLC, driver mutation negative, there is probably no fun.
So can we
Thank you.
conclude, sir? Yeah.
Yeah,
Thank
yeah,
you.
please.
Yeah. Thank you, sir, for this talk, wonderful talk, and thank you for guiding us. And for the next session, I invite Dr. Tarachand Gupta, who is senior medical oncologist at Bhagwan Mahavir Cancer. And just he will update about the ESCO 2050 and 2025 key takeaways in GI cancers. So over to you, Dr. Tarachand.
Yeah, I will share my slides. Where is the? Yeah, there are 61 slides, and we have picked up 3-4 trials, which are 4 trials which are positive. We say this is positive. Positive Wednesday, right? So first we are talking about the atezolizumab. That means the atomic trial. And atomic trial, what atomic trial says that if you forget to give neoadjuvant immunotherapy in colon cancer in the beginning, then you can offer adjuvant atezolizumab along with the chemotherapy, according to this trial. So we are let's start. This is the randomized trial of standard chemotherapy alone or combined with atezolizumab as adjuvant therapy for patients with stage 3 deficient mismatch repair colon cancer.
Sir, make it full screen, please.
Yeah, I am making, and we will go quickly because these are 61 slides. So the key takeaway points of this study was, as I highlighted in the beginning, that this is doing magic in if we are doing adding atezolizumab in DMMR patients, stage 3 colon cancer patient. So standard adjuvant chemotherapy for stage 3 colon cancer consists of Capox or Folfox, and 15% of colon cancer have deficient MMR and may display resistance to 5-FU. Despite adjuvant chemotherapy, approximately 30% of stage 3 patients will experience recurrence of their cancer. While approved for DMMR metastatic cancer, it is unknown if an immune checkpoint inhibitor will improve outcomes after surgical resection of DMMR stage 3 colon cancer. So this was the study design. In this age, age was taken 12 or more, and histologically confirmed R0 resected patient with DMMR by ISC. PS, good PS with a 1 or 0 or 2, no prior chemotherapy or radiotherapy. So patients were stratified according to the T stage, N stage, and tumor location, proximal versus distal. And 10 weeks or less post-surgery, patients were randomized 1-to-1 chemotherapy alone or chemotherapy plus atezolizumab, followed by atezolizumab 6-month maintenance. So total 1 year duration of atezolizumab. Primary endpoint were disease-free survival, and secondary endpoints were overall survival. So we are discussing that the 712 patients were randomized. At the second interim analysis, the stratified log-rank test for comparing DFS between arms crossed the protocol-specified interim boundary of 0.009 for efficacy, and the Alliance DSMB released the data. So this is the data cutoff point, February 4, 2025, median follow-up was 37.2 months. So this is the consort diagram. Baseline characteristics were well matched. The median age was less than 65 or 65. And most of the patients, 31% patients were T4 in the atezolizumab arm and same in the only chemotherapy arm. So we can see that the T4 disease was quite common around T31 and T3 patients were 56 or 57%. Remaining were T1, T2. And N2 disease was also quite common, around 36% in both arms. So this is the median treatment duration, around 5.5 months for FOLFOX and 10.9 months for atezolizumab. Primary endpoint disease-free survival, around it is 86.4% at the 3 years and 76.6% for the chemotherapy. So as we can see the forest plot that in all all the subgroups of the patients, including the T, N, and A's, all patients got benefited with the addition of atezolizumab. Overall survival data was not mature, so median OS follow-up is 42.5 months. The OS comparison may be confounded by subsequent immunotherapies. So safety summary, the toxicity profile was according to the immunotherapy and chemotherapy respectively. No new safety signals were observed. So to conclude this study, median FOLFOX6 plus atezolizumab demonstrated a statistically significant and clinically meaningful 50% risk reduction in recurrence or death over median FOLFOX alone. The safety of median FOLFOX plus atezolizumab was in line with the known safety profile of each, with a manageable increase in non-febrile neutropenia. Atezolizumab plus median FOLFOX6 is a practice-changing treatment for patients with dMMR stage 3 colon cancer. So next study is the consolidation of the CheckMate 577. That means the updated OS analysis, because initially this was criticized that there was OS data was not there for the CheckMate 577. So this was presented in this ASCO for the OS analysis. So after a 5 year of minimum follow-up, DFS and DMFS benefits were sustained. Adjuvant nivolumab plus versus placebo in patients with resectable esophageal cancer and esophageal gastrojunction cancer following neoadjuvant CRT. Median DFS continued to be doubled with the nivolumab, 21.8 versus 10.8 month. So this is a 16.4 month improvement in the median OS and higher 5 year OS rates versus placebo, with the clinically meaningful benefit. Hazard ratio was 0.85, that means 15% reduction in the death. And it was more pronounced in the PD-L1 positive patients. Considering the higher rate of subsequent systemic therapies in the placebo group and hoc analysis, accounting for the potential confounding effect of subsequent therapy suggests OS benefit within nivolumab versus placebo. Nivolumab was well tolerated without new safety signals, and these results further support adjuvant nivolumab as a standard of care treatment for patients with resected esophageal cancer and gastroesophageal junction cancer and residual pathological disease after neoadjuvant CRT. Subcutaneous nivolumab is also FDA approved for the patients with resectable esophageal cancer and gastroesophageal junction cancer and residual pathological disease after the neoadjuvant CRT and offers an alternative route of administration. So background, we have discussed that OS data was not there. So this study was presented for the OS data in this ASCO. This is the CheckMate 577 global phase 3 randomized data, where the patient of stage 2-3 esophageal, gastroesophageal junction cancer, adenocarcinoma or squamous cell carcinoma. Patients were randomized to neoadjuvant CRT plus surgical resection 4 to 6 weeks prior to randomization into the nivolumab or placebo. If the screening was R0 resection, residual pathological disease, that means YP-T1 or more, or YP-N1 or more, with a good performance status. Patients were stratified according to histology, pathological lymph node status, and tumor cell PD-L1 expression. Primary endpoint was disease-free survival. Secondary was the overall survival rate at 1, 2, and 3 years. And exploratory endpoint safety and distant metastasis-free survival. At the data cutoff, November 7, 2024, the median follow-up was 78.3 months. So age was less than 65 in both the arms, and performance status was good. And patients, all the randomized patients were ongoing was a disease-free survival, where the Median DFS was 21.8 versus 10.8 month. At 5 year, it is disease-free survival is around 37 versus 29%, making 8% absolute difference at 5 years. Distant metastasis-free survival 27.3 versus 14.6 month. And at 5 year, it is 29% versus 38%. Overall survival 51.7 month median versus 35.3 month. That is around 16 month absolute difference. At 16 month, that means at 5 year, it is absolute difference of 5% 41 versus 46% in favor of nivolumab arm. So overall survival subgroup analysis, PDL1 CPS is around, we can see that the one or more than one, it is favorable. If this is negative, then in this subset, nivolumab could not demonstrate the benefit. Otherwise, all the subgroups except that gastroesophageal junction cancer, and even we can see in this forest plot, Asian population but also not get benefited. So this is the PDL1 positive patients, 45.5 versus 33.5 month with a hazard ratio of 0.79. With ATLAS CPS less than 1, it is 39.2 versus 52.8 month in CPS less than 1. So that is the net rating in the PDL1 negative patients. And overall survival adjusted for the subsequent therapies. This is systemic anti-cancer therapy, 37% or 199 patients. And in placebo arm, 50% of patients took the subsequent systemic anti-cancer therapy, around 132. Around chemotherapy was 37 versus 48. Targeted therapy 6 versus 9. And immunotherapy, anti-PDL1 5 versus 14% in placebo arm. And anti-PDL1 less than 1 and 1. Anti-CTLA4 less than 1, both are BCG vaccine less than 1 and 0. So median OS, if the patients are adjusted for the subsequent therapy, it is 38.6 versus 20.2, that with the hazard ratio of 0.73. So ultimately, if we adjust for the subsequent therapy, then it could demonstrate the benefit. So a post and ad hoc analysis using two-stage method suggests OS benefit with nivolumab versus placebo when adjusting for the confounding effect of subsequent treatments. So this is the safety summary. There is no new safety signals in the nivolumab arm. All the safety, all the side effects were in a line of nivolumab. So to summarize, as we have already seen in the first slide, that already we have summarized that there was 16-month OS benefit, but it was more pronounced in the PDL1 positive patients and deteriorating in PDL1 negative, although confounding factor was the subsequent chemotherapies. So now this is the Matterhorn, the most highlighted study in this ASCO for the GI, randomized phase 3 study of durvalumab plus 5-FU, leucovorin, oxaliplatin, and docetaxel, that means FLOT, in resectable gastric and gastroesophageal junction cancer. So this is the key takeaway. The addition of durvalumab to FLOT improved event-free survival in resectable gastric and gastroesophageal junction adenocarcinoma. So as we know in the background that the FLOT is the approved regimen for the perioperative chemotherapy, perioperative treatment and the esophageal junction cancer or gastric cancer. So adding anti-PD-1 therapy to the chemotherapy improves survival in the metastatic gastroesophageal adenocarcinoma. Its role in the perioperative setting remains uncertain. So Matterhorn was designed to evaluate whether adding durvalumab, an anti-PD-L1 antibody to FLOT, improves outcomes in patients with resectable localized gastroesophageal adenocarcinoma. So this was a phase 3 global randomized double-blind placebo-controlled study where the study population was gastric and gastroesophageal junction adenocarcinoma, stage 2 to 4A, no evidence of metastasis. No evidence of metastasis, no prior therapy, ECOG PS 0 or 1, global enrollment in Asia, Europe, North and South Africa, stratification factor versus Asia versus non-Asia, clinically node positive versus node negative, PDL1, this was a TAP less than 1 versus TAP 1 or more than 1%. So to randomize 1-to-1, durvalumab plus FLOT versus FLOT plus placebo, After the 2 months, it was the surgery. And then again 2 months, it was continued for the flood followed by placebo. And in durvalumab arm, it was durvalumab plus flood for the 2 months, then the durvalumab maintenance for the next 10 cycles every 4 weeks. So that means around 14 cycles of durvalumab. So primary endpoint was event-free survival and secondary overall survival and HCR. So primary endpoints were defined as the EFS, time from randomization to event or death. Key secondary endpoints: overall survival, interim analysis at 34% maturity with minimal alpha spend, final OS ongoing. PET-CR, no residual viable tumor in the primary set, and nodes at surgery reported at ESMO 2023. Secondary endpoints: DFS, time to disease recurrence or death in participants with R0 resection. These are multiple testing procedure and alpha allocation. PET-CR, two-sided, alpha 0.1%. Event-free survival, two-sided, alpha 2.39%. Overall survival, two-sided, alpha 0.01%. Final OS, two-sided, alpha 4.99%. So this is the durvalumab plus flood participant disposition. So completed durvalumab or placebo, 97% of the patients completed and 95 in the placebo arm. Completed any flood, 96 versus 95. Surgery was done around 90% of the patients in both arms. R0 resection was 92%. Received any adjuvant treatment around more 75% in both arms, around 77 or 74. Completed durvalumab or placebo, 52%. Completed any flood, 60% patients. Active follow-up and data cutoff 68 versus 59%. Median age was, it is quite elderly patients were taken around, sorry, it is 62 and 63, but male patients were taken around 69 and 75, or 69 versus 75 male percentage. Non-Asian patients 81 and Asian patients 19%. Site of the tumor, gastric versus the gastroesophageal junction, 68 versus 32. T-stage T4 was 25% in both arms, and remaining were the non-T4. Node positive patients around 70% in both arms. PD-L1 positive 90% in the both arms. And histological type, intestinal variety 52 versus 50%. And diffuse variety is around 27 versus 25. Unspecified adenocarcinoma 21 versus 25. MSI status, MSI high was 5% in both the arms. Non-MSI high, 64 versus 65, and not available or missing in 30% of the patients in both arms. So primary endpoint of event-free survival, it is around a median EFS not reached in the durvalumab arm, while it was 32.8 months in the placebo arm, with a hazard ratio of 0.7. At 18 months, the EFS is 64 versus 73, and 2 years it is 59 versus 67%. So it is 31.6 month versus 31.4 month follow-up, median duration follow-up in both the arm. EFS in key subgroups, we can see that the all patients group were most benefited in the irrespective of PD-L1 and age or primary tumor location, ECOG performance status, and histological variety. All patients got benefited with the experimental arm. So if we see the median OS at 18 months, it is 77 versus 81%. At 2 years, it is 70 versus 76%. So median OS was not reached versus 47.2 months in the placebo arm with a hazard ratio of 0.78. PET-CR rate 19 versus 7% in favor of experimental arm. Disease-free survival, it is not reached in the durvalumab arm, while it was 39.8 months in the placebo arm. At 18 months, it is 73 versus 79, and at 24 months, it is 66 versus 24 months. 66 versus 75%. Treatment delivery, median number of neoadjuvant cycles, both arms same. All patients received the median number of cycles, and median number of adjuvant cycles, it is durvalumab arm, it is obvious, where 12 cycles, all the cycles are planned. And also the adjuvant was also the same. So all patients received all the treatment. Median number was same on all the patients, both the arms. So number of neoadjuvant cycles of durvalumab or placebo plus 1 or more, it is 100%, and 2 or around 9, and equal to 2, it is around 97% patients. Number of adjuvant durvalumab or placebo plus minus float, 1 or more, around 75 in both the arm, and 2 or more, it is around 73 in the durvalumab, and plus float, it is 67, while in the placebo it is 72 versus 68. So total 12 cycles, 52 and 51% of the patients. Safety signals possibly related to any treatment related around grade 3 or more adverse event related 70% in the both are, and any study treatment related it is 60%. The adverse event leading to discontinuation of any study drug around durvalumab or placebo, it is around 10% in the durvalumab, and in the placebo 6% of the patients. So common adverse events are balance with the chemo. It is matching with the chemotherapy versus chemotherapy, and the durvalumab are having the immunotherapy related side effects. So to conclude, the durvalumab with float significantly improved event-free survival versus float alone in resectable gastric and gastroesophageal junction adenocarcinoma. EFS benefit was consistent across subgroups and geographic regions. No new safety concerns were identified. OS data are encouraging. Final OS analysis pending. Matterhorn supports global adoption of perioperative durvalumab with float as a new standard for patients with localized gastric and gastroesophageal junction adenocarcinoma. So this is the final study for the today session. It is breakwater analysis of first line encorafenib plus cetuximab plus chemotherapy.
I think this will present in the last session by the Dr. Lalit Sharma. So I think we will discuss. Can we discuss in the last?
So this is also beneficial, and breakwater. This is the new combination with the you can combine cetuximab with Vera. So I conclude my presentation.
So thank you, Tara, for this talk. So I think you have discussed the addition of immunotherapy in various GI cancers. So I think, do you agree that in the last trial, so durvalumab can be added with this float regimes in this operable gastric cancer as a neoadjuvant regimes?
Was in the recent update which I saw around 15-20 days back, that it was OS was pronounced in only EFS most pronounced were in the PD-L1 positive patients only. So I will say that we should wait for the OS data, and for as of now we should select patient carefully, and if patients are PD-L1 positive, then we should offer the Matterhorn.
Okay. And first trial you have mentioned the AT can be added along with this MSI or dMMR patients in stage 3. So do you believe that we should add or not?
We should add if the patients have not received any neoadjuvant immunotherapy and patients are dMMR positive. Yes, but it is still there is a declaration that OS data is still not there. But till OS data is there, we can give a benefit of event-free survival to the patients.
And even
stage 3 colon cancer.
In CA esophagus, addition of this nivolumab. So I think you have said that a neoadjuvant CT-RT followed by the surgery and can offer the nivolumab if there is any residual disease. So if there is in which subset, if PD-L1 positive, then we can add, or irrespective of PD-L1 we can add.
As we saw the data that there is a PD-L1 positive patients were got benefited, and one very surprising, very strange data is that Asian population was not having any benefit of nivolumab in that forest plot. So, but the number of Asian population was less, and if we see that there is a confounding factor of subsequent therapy, it may be there in any trial. So we cannot say that it is the only confounding factor in this trial only. This will be the confounding factor in every trial. So as of now, I will say that if the PD-L1 positive patients are there, then we should offer nivolumab, otherwise not, because the data is showing that PD-L1 negative patients, placebo was better than nivolumab.
So Mani sir, any inputs from your side about immunotherapy in GI cancer? I think yes, sir.
Matterhorn definitely yes. It's practice changing. This what you call stage 3 patients. And these two trials I'm taking at the positive. That is the FLOT plus durvalumab. Another is the stage 3 colorectal surgery and adjuvant treatment followed by the atezolizumab. My question to Dr. Tarachand is that suppose you have the stage 2 colorectal patient, typically colon cancer, and MMR is high. Typically, we don't give them chemotherapy, but few patients they do recur. So, what is your thought process? Should they be taken up for
Sir,
the
dostarlimab is
adjuvant?
going to be launched. Dostarlimab is
Sorry?
going to be launched most probably. I think this patient will come around after the 15th August most probably. Before that, I think patient should not come. So in that trial 2022, so dostarlimab was offered to the rectal cancer patients. If I exactly recollect the data, that all the patients were in CR, clinical CR.
That
So
is
in that case, we
after
can
positive or deficient MMR or MSI high for that matter. Is there any thought process of thinking of the atezolizumab only as adjuvant
no, sir.
treatment?
In this trial, it was only the stage 3 patients were taken, and for stage 2, already there is a practice is if the MSI high, then we can observe also, and MSI low, that we can give the capecitabine or 5-FU. But at the same time, one more study that was BESPOC study, I think that circulating tumor DNA is being evaluated. If it is positive, then yes, we can offer chemotherapy also.
So these are two new things I see from this ASCO, that is the Matterhorn and this what you call atezolizumab based trial. Durvalumab and the atezolizumab in the respective setting.
So, thank you, Tarachand, and thank you, sir. Trial. So, I think over to you.
आज पानी को डंडे से तोड़ेगा ललित लाठी मार के पानी अलग के बोलते अलग नहीं होता, लेकिन आज करेगा ये.
So at the outset, I thank the organizers, especially Dr. Devesh Bose, for organizing this academic feast and helping us learn about the oncological disorders in a far better manner. So the job cut out for me is to discuss the breakwater trial. So this particular trial, this analyzed the first line encorafenib along with cetuximab and the modified FOLFOX6 regime against the standard of care chemotherapy in this particular setting. So we'll go to the conclusion at the end. So the background is BRAF V6 BRAF mutation. It occurs in anywhere around 10% of the patients with metastatic CRC. Usually these patients do not fare well, and they patients do not show favorable responses with the established standard of care chemotherapeutic regime. So there was always a kind of desire and need for introduction of better targeted therapies towards this particular disorder. So Breakwater, with this background, was a study which was open label multi-center phase 3, which included adult patients who had not been exposed to any sort of systemic treatment with measurable disease, BRAF mutation positive, and adequate bone marrow, hepatic, and renal function. The patients who had received some sort of BRAF or EGFR directed therapy before were excluded. Patients with symptomatic brain metastasis or MSI high or MMR deficient tumors were also excluded. So were patients with RAS mutation. Patients were stratified in a 1:1:1 ratio to encorafenib cetuximab arm. The other arm, the experimental arm, had encorafenib, cetuximab, and modified FOLFOX, and the third arm had standard of care chemotherapy as per the practice at the particular center. The patients were stratified on the basis of area of origin and ECOG performance status. The primary primary endpoint was PFS and overall response rate for the experimental regime, and the key secondary endpoint was overall survival. So all of these slides are borrowed, and these are showing the primary analysis for overall response rate and the interim analysis for overall survival. As far as the summary of the disposition goes, the median duration of treatment was 28 months versus 20.4 months in the observational arm. The median overall survival was 10.3 versus 9.8, and the discontinuation rate was 41% versus 66%, and most of these discontinuations were either because of the adverse events or because of progressive disease. As far as the demographic factors were concerned, both the kind of arms were pretty well matched, a bit for age, gender, performance status, side of the tumor, the disease load, and presence of liver metastasis, the magnitude of CA at the baseline, and CRP levels at the baseline. At the publishing of the results, the experimental arm showed a significant improvement in the overall response rate of 60.9 months, 60.9% versus 40% in the standard of care arm. And there was a significant improvement in the time to treatment also, with a median range of 7.1 versus 7.3. The estimated duration of response was also better, 13.9 months versus 11.1. And the patients who had a duration of response for more than 6 months was 68% versus 34. And for those who had duration of response for more than 12 months was almost double in the experimental arm, that is 22% versus 11.4%. And this advantage was seen across the predefined treatment subgroups, though the advantage was far more for younger patients, that is less than 65 years, and patients who had a left-sided tumor compared to the right side, and in the patients who had liver metastasis. The interim overall survival also was did have a tendency towards improvement in the experimental arm of around 79% at 12 months follow-up versus 66% in the observational arm. This particular efficacy did come at a cost, and the overall incidence of the adverse events was more in the combination arm versus the standard of care, and there was more chances of adverse events related to any drug in the combination arm, though the chances of interruption was more in the or discontinuation was more in the standard of care arm because of the progression. As far as the safety profile is concerned, the most common side effect in both the arm was nausea, but the most common grade 3 or more, that is severe side effect, was neutrophil count neutropenia, especially in the combination arm. Rest of the other common side effects were anemia, diarrhea, and reduced appetite, along with other GI complaints and hematological toxicities. Dose modifications were required in the combination arm for obvious reasons. And to conclude, Breakwater did show a statistically significant and clinically meaningful benefit in the overall response rate for the dual primary endpoints in the and moreover, the combination was generally well tolerable, and there was pre-specified analysis of mature PFS OS data are planned, and the Breakwater study supports use of the combination as a new first-line standard of care for patients with BRAF mutated metastatic CRC. Thank you for the patient hearing, and I would like to hand over the proceedings to the
Thank you, Lalit.
organizers.
Thank you, Lalit. Just want to ask one or two things. The number of patients you have encountered BRAF positive in your OPD in metastatic.
I would say so far none.
So far none. So I think if you have encountered this type, so without encorafenib, so how will you approach this type of patient? How you start? If suppose metastatic
as
patient.
far as my as far as my take here goes, what I have learned so far is that even with encorafenib alone itself, the toxicity profile is not that easy. It's not an easy to handle drug. So with the combination chemotherapy, that too 3-drug multi-drug regime, we are going to find it very difficult to handle, and maybe over a period of time, as we see more and more patients, we might become more wiser. But this seems to be a toxic regime, especially for our population. So I don't know whether we'll be able to manage the toxicities.
So I think still encorafenib is available or not in India?
No, I don't think so.
So thank you, Lalit, for this talk and for this ending talk. So today we discussed the first part is the lung cancer in the meetings, as in second part GI cancer. So we know that the addition of this IO in the perioperative settings, even with this EGFR mutated settings, the addition of this osimertinib, and in few discussion osimertinib with chemo in metastatic settings. So we all know that facts. How can we use appropriate targeted drugs as well as chemotherapy in the lung cancer? In the GI cancer, the addition of this immunotherapy. So I think the recent trial that presented in the ESCO, the Durva in the along with this plot in the operable in the neoadjuvant trial, the gastric cancer. And the next is the DMMR stage 3 the colon cancer, the addition of AT. So I think these two trials are new, and the next is the breakwater trial. So encorafenib plus cetuximab along with this chemotherapy in the BRAF mutated cancer. And the very well discussed, all the panelists, all the speakers, and all the participants as the moderated by the session, the sir. And thanks to the Horizon team for supporting the platform, and thanks to all pharma companies for the sponsoring their sessions and for the for guidance. So thank you all, and we will ending this session, and good night, and we will meet tomorrow. The next session is the breast cancer. Today is the breast. Tomorrow is the breast and head and neck cancer. We will discuss. So thank you all, and good night. Yeah, thank you all. Thank